Not all study designs are equal, and so there's different strengths of evidence that can be derived from these different study types. And so I'm going to be talking from the least strong or the weakest evidence-based studies, and we're going to be working our way up to the top, which is the stuff like clinical trials and systemic meta-analyses. And so kind of at the very base of our stairway here is the first thing that we're going to call a case report or a case series. And so basically with case reports, what happens is, a hospital or a physician will release some kind of medical record that obviously has been kind of de-identified, but they're saying, what a patient looked like and, these interesting symptoms that they had or some kind of conditions and how they ended up diagnosing them with this disease. And so it's purely just this descriptive thing. So there's no analysis here. There's no, drawing any correlations or any of that stuff. It's purely just saying like, hey, here's this really interesting case that people might be interested in. So, COVID right now, huge deal. So, this was a big thing with those early cases of COVID and people thinking hydroxychloroquine might be a great way to solve this thing. And I remember UC Davis was publishing these case reports where they were talking about patients that they had who, they were on the brink of death and they did these interventions and they described the patients and their medical records. And so that is the least strong evidence you can have from a clinical perspective in this stuff, but it is potentially useful things to know. So that's what case reports are. So moving up here, another type of study that we have is called a cross-sectional study. Why do we call it a cross-sectional study? Is we think of time as like this continuum. And so basically cross-sectional studies just cut through and look at one single point in time. And the whole point of these cross-sectional studies is to tell us the prevalence of a disease. So that's a really big thing. Like during COVID, how many times were people reporting the cross-sectional study saying, look at how many cases there are out there right now, and look how many new cases there are. So it was all focused around this stuff of, again, really just describing what's happening, but not saying anything about what's causing it or, things we can do to fix it. It's purely just a descriptive thing telling us like, here's what's going on. So not too much to act on there other than being like, okay, thanks for letting me know. But the next thing here, and this is where things get more interesting and, a bit confusing also, but I'm going to try to make this clear, is the difference between something that's referred to as a case control study and a cohort study. And so this is where we begin to look at groups of people, and there is a key difference that you need to remember between these two. And so with case control studies, we are dividing people by their disease status. And with a cohort study, we're dividing people based on the risk factors that they have. And so a great kind of story to think about with this when we're thinking about the differences between these two is the smoking and whether or not that causes lung cancer. So the thing that the case control studies did is they looked at people who already have cancer, specifically lung cancer, and they said, in this group of people who have lung cancer, how many of them have a history of smoking cigarettes? And so it's kind of like you're reverse engineering this whole thing to be like, you can clearly see that there was this link between the smoking and the lung cancer, because we're seeing so many more smokers in the population of people or patients who have lung cancer. So therefore smoking must be doing something here. And the issue is that with these, specifically the case control studies, is that there's recall bias. And so humans are going to get emotional or they're not going to recall correctly. And it's all retrospective. Like we're looking back in time at this thing to say like, okay, of all the people with cancer, these are that specific, features of that group. So what sets it apart from a cohort study, which is considered a more strong, the evidence from cohort studies is considered more strong than that from a case control study, is that with the cohort study, we look at groups of people by their risk factors. And so what we would do is we would say, okay, I'm going to conduct what is called a prospective cohort study. I'm going to take groups of people and we're going to follow them over time, over like the next 10 years. And so what we're going to do is we're going to take these groups of people and we're going to break them apart based on what they do. So if we suspect that smoking is this thing that's causing lung cancer, then instead of looking at who already has lung cancer, we're going to say, okay, we've got this group of people who smoke, daily a lot, and we've got this group of people who don't smoke a lot. And so both these groups are going to go forward in time together, and we're going to check in on them, and we're going to look at the things that come out of this. And specifically what we care about with the cohort study is this thing called relative risk. And so what we get out at the end of the day from a cohort study is relative risk, because we're able to say, okay, between these two groups with the non-smokers and the smokers, the relative risk of people smoking increased their likelihood of developing lung cancer. The thing that you get out of a case control study, where you already started with people who had lung cancer and you're looking backwards, is a thing called an odds ratio. And so those are the two key outputs from those two studies that we care about. And then these have all been kind of observational studies so far, but now we're going to move into something that is called an actual experimental study. So this is where a lot more money comes into the picture, and we are testing some kind of intervention. And so great example again with COVID was all these articles coming out and papers for all these treatments. So like treatment A of COVID, does the vaccine work, whatever. So the way that these actual experimental studies work, and they're specifically called randomized controlled trials, is that they are built so that they minimize the effect of human emotions or any biases. So the way we do this is by, number one, if you are enrolled in a randomized clinical trial or controlled trial, basically you're not even going to know if you're getting an active ingredient or not. The person who gives you that potentially active ingredient isn't going to know if it's an active ingredient either. And the people who analyze the data are not going to know if it's an active ingredient or not. And so basically what we have is we have a placebo or a control group that's going to receive the standard of care, or a sugar pill or whatever that does nothing. We know it does nothing. And then another group of people is going to get the actual thing that we're testing. So, a lot of times with clinical trials, there's already a product out there that does what your product that you're trying to get through clinical trials does. And so you're trying to see, does it actually provide any benefit relative to the people who already take the standard of care, what's already on that market. And so that's a big thing that comes out of these clinical trials. But basically, at the end of the day, what we get out of these randomized controlled trials is these two groups of people, and we can say with a lot more confidence and certainty that this particular medication or this treatment or this vaccine was effective or was not effective, based on the fact that we're doing this prospective study where we've got these two groups of people, our control group who is receiving a placebo and another group who is receiving the active ingredient, and we're able to see whether or not there is a difference here. So it's much more strong evidence than something like a cohort study or a case control study, or especially like a case report, where the thing to remember about case reports is you've only got one guy or one patient, so n equals 1. So these are very close to anecdotes. So it's very hard to kind of draw any statistically meaningful conclusions out of that data. So that's the key study designs. And then finally, what we have are things called meta-analysis or systemic reviews. And so the thing to note with these is that basically what they do is they aggregate the existing data that we have from a bunch of randomized controlled trials. And so, the hope is that by looking at an even bigger data set with, even more analysis and statistics, we'll be able to draw, potentially some additional conclusions that only come from having an even larger amount of data. So that's going to wrap things up for this video. Just kind of to recap, ideally, if you're a physician or a healthcare professional in practice and you want to know, is this treatment going to be effective for my patient? the first thing you should be looking at are meta-analysis or random controlled trials, because those are the strongest evidence that a particular thing will be effective. But you do have all these other things, and so I think it's a pretty common story, with people saying, "Oh, well, I heard my friend took this and it helped them." Like that's a very similar thing to like what a case report would be. Very well may have helped them. We just don't have enough evidence to really know for sure or not. So that's the reason why, ideally you would have some kind of random controlled trial to look to for evidence. So that's going to wrap things up for this. Hope it's helpful. Thank you all for watching. Let me know if you have any questions, and I'll talk to you guys next time.